My name is Lydia Kaudzani, and I'm a neurosurgery resident. I'm in my fourth year at Augusta University, which is in the United States. It's in Georgia. So today I will be presenting the history of neurosurgical management of ischemic stroke. This paper was published in Intech Open Book Series. Stroke is a major cause of morbidity, and it remains the second leading cause of death worldwide. Stroke is also the third most common cause of disability, with significant increase in stroke burden in the world, and especially in the developing countries. On average, in the United States, someone has a stroke every 40 seconds. Stroke is a health condition that neurosurgeons deal with on an everyday basis. Over the years, the management of ischemic stroke is a field that has been rapidly evolving and advancing. The focus of this presentation will be to discuss the history that has led to the current techniques used by neurosurgeons for treating ischemic stroke. The American Stroke Association for the 21st century defined stroke as brain, spinal cord, or retinal cell death attributable to ischemia based on one, pathological, imaging, or other objective evidence of cerebral, spinal cord, or retinal focal ischemic injury in a defined vascular distribution. Or second, clinical evidence of cerebral, spinal cord, or retinal focal ischemic injury based on symptoms persisting more than or equal to 24 hours or until death, and of course, other etiologies excluded. Stroke is divided into ischemic and hemorrhagic. Hemorrhagic stroke is further divided into intracerebral and subarachnoid hemorrhage. Approximately 85% of all strokes are ischemic, with the remaining 15 being hemorrhagic. Risk factors of strokes have been well established, some of which are hypertension, hyperlipidemia, diabetes, and smoking. Prevention of stroke can be achieved by managing the above risk factors. Over the years, our understanding of stroke has greatly improved. The first documentation of stroke in the literature was the word apoplexy, which was documented in the Hippocratic corpus and refers to a person collapsing while retaining pulse and respiration. According to Hippocrates, apoplexy was secondary to heating of the head blood vessels that brought phlegm or caused the flow of blood bile to the head. Galen claimed that stroke was the result of humerus imbalance, resulting in blocking the transmission of the animal spirit. During the medieval era, the concepts around apoplexy remained grossly unchanged. More information into the cause of apoplexy was obtained during the Renaissance era, where autopsies were permitted and the ancient works were translated. In 1658, Johann Jacob Wepfer published Historia Apoplecticorum, which was the first time that apoplexy was related to intracerebral hemorrhage. In 1689, William Cole was the first to use the term stroke to refer to apoplexy. As shown in the above outline, there have been various people who have contributed to the development of the carotid endarterectomy between 1852 and 1969. Of note, in 1953, DeBakey successfully completed the first CEA surgery for a patient with cerebrovascular insufficiency that he did not, though, publish until 1957. In the meanwhile, in 1956, Cooley was the first to publish a case report on a patient undergoing a successful CEA. In 1969, the joint study of extracranial arterial occlusion was published that showed that in 2,400 operations performed between 1961 and 1968, there was a 4.5% surgical mortality. The indications for CEA remained unclear, and given the surgical risk associated with the surgery, it took years before it became the standard of care. In 1991, the North American Symptomatic Carotid Endarterectomy Trial, NACID, and the European Carotid Surgery Trial proved that patients with symptomatic carotid stenosis of 70 to 99% who underwent a carotid endarterectomy had better outcomes when compared to patients who were treated medically. Specifically, the NACID study showed that there was an absolute risk reduction of 17% of having any ipsilateral stroke at 2 years, and an absolute risk reduction of 10.6 for a major or fatal ipsilateral stroke when comparing patients who underwent CEA versus those who underwent only medical management. The ECS trial showed that patients with carotid artery stenosis of 70 to 99% had a 6-fold reduction in their risk of experiencing stroke during the next 3 years if they underwent surgical treatment versus medical management. A milestone in the management of ischemic stroke occurred in 1995 when the National Institute of Neurological Disorders and Stroke RTPA Stroke Study, NINS study, showed that administering intravenous recombinant tissue plasminogen activator, TPA, within 3 hours of symptoms onset had favorable outcomes in stroke management. The NINS study was a randomized double-blind trial with patients either randomized to receiving intravenous TPA or placebo within 3 hours of the onset of symptoms. The results of the study showed that neurological improvement was similar between the two groups 24 hours after treatment, and better in the group that received intravenous TPA at 3 months. The European Cooperative Acute Stroke Study, ECAS-1, published in 1995, was a randomized controlled study that divided subjects into 2 groups: those receiving 1.1 milligrams per kilograms of body weight of intravenous TPA or placebo. Patients were included in the study if they presented within 6 hours from onset of symptoms and had moderate to severe neurological deficit. Patients receiving intravenous TPA had better MRS at 90 days and better neurological recovery in comparison to the placebo group. The incidence of intracerebral hemorrhage and mortality rate was similar between the 2 groups. Other randomized control studies, including the ECAS-2 in 1998 and the ALTIPACE thrombolysis for acute non-interventional therapy ischemic stroke, Atlantis B, in 1999, urged against the use of intravenous TPA beyond 3 hours in management of ischemic stroke. This conclusion was based on the high incidence of intracerebral hemorrhage that was observed in those who received intravenous TPA. In 2008, ECAS-3 study was a randomized control study that showed administration of intravenous TPA to patients with ischemic stroke up to 4.5 hours after the onset of stroke symptoms was beneficial. Patients were randomly assigned to either receive intravenous TPA or placebo, and the median time for administration of the medication was 3 hours and 59 minutes. The study showed that the group that received TPA had better outcomes than the placebo group. Both incidences of any intracerebral hemorrhage and symptomatic intracerebral hemorrhage were higher in the treatment group versus the placebo group. In 2005, the mechanical embolus removal in cerebral ischemia, MERCY trial, revolutionized the way ischemic strokes are managed. This was the first study that showed how endovascular embolectomy using a first-generation device can improve outcomes of ischemic stroke. The MERCY trial used the embolectomy device, MERCY Retriever, for patients who presented within 8 hours of onset of stroke and were otherwise ineligible for intravenous TPA administration. The study showed that recanalization was achieved in 48% of patients who underwent embolectomy, and the risk of intracranial hemorrhage was significantly lower in comparison to those receiving intravenous TPA. In 2008, after the development of the MERCY Retriever, the Penumbra system was developed. The Penumbra device is the second-generation thrombectomy device that is inserted all the way through the clot, followed by application of mechanical aspiration with the use of a suction pump. By using the Penumbra system, partial to normal reperfusion was achieved in 81.6% of patients, a percentage higher than that achieved by using the MERCY Retriever. Intracranial hemorrhage was observed in 28% of patients on post-procedural 24-hour CT scan. However, only 11.2 were symptomatic. Despite the increase in intracranial hemorrhage observed with the Penumbra device in comparison to the MERCY Retriever, the 90-day MRS of less than or equal to 2 was similar between the two groups, with 25% for the Penumbra system and 27.7% for the MERCY Retrieval. Shortly thereafter, stent retrievers were developed for the use as thrombectomy devices. In 2012, a third-generation mechanical thrombectomy device was introduced. The solitary flow restoration device versus the MERCY Retriever in patients with acute ischemic stroke was studied. The SWIFT study was a randomized, parallel group, non-inferiority trial that showed that solitary flow restoration device is significantly better than the MERCY Retriever device. In particular, patients treated with the solitary flow restoration device had a rate of recanalization of 61% in comparison to 24% in those treated with the MERCY Retriever device. With the use of the solitary flow restoration device, the rate of symptomatic intracranial hemorrhage was decreased, and their overall neurological outcomes were better. The next step in the management of acute ischemic stroke was to determine whether endovascular thrombectomy was superior to standard medical care alone. There were 5 key randomized control studies that aimed to answer this question: Mr. Clean, Escape, Revasc, SWIFE-TRIM, and Extend IA. Subsequently, a meta-analysis published in 2016 looked at the results from the above 5 randomized control studies. There were 1,287 patients that were included in the study and who had an acute proximal anterior circulation stroke. Prior to randomization to the 2 groups, patients received intravenous TPA if they met the inclusion criteria. The major results of this meta-analysis were: first, endovascular thrombectomy led to reduced disability at 90 days. Second, the risk of intracerebral hemorrhage and symptomatic hemorrhage did not differ between the 2 groups. And 3, the mortality rate was similar between groups. In 2018, 2 major randomized control studies, the DAWN and the DIFFUSE-3, were published. The data collected from these studies showed that mechanical thrombectomy can be extended to 24 hours from onset of stroke symptoms. The DAWN study randomized patients to receive either intravenous TPA alone, the control group, or thrombectomy plus intravenous TPA, the experimental group. The patients had an intracranial internal carotid artery or proximal middle cerebral artery occlusion and were last known well 6 to 24 hours prior. The patients included in the study had disproportionately worse neurological exam in comparison to the infarct volume that was observed in imaging. The study showed that at 90 days, the thrombectomy group had a better MRS score and improved functional independence. Adverse effects such as intracerebral hemorrhage and death were similar between the two groups. The DIFFUSE-3 study was a multi-center randomized open-label trial in which the control group received intravenous TPA and their experimental group received endovascular therapy plus intravenous TPA. Patients who were included in the study had onset of symptoms 6 to 16 hours prior to presentation, were found to have a proximal middle cerebral artery or internal carotid artery occlusion, with initial infarct size less than 70 ml and a ratio of volume to ischemic tissue on perfusion imaging to infarct volume of 1.8. The study showed that patients who underwent mechanical thrombectomy had an increased chance of being functionally independent, and the 90-day mortality rate was 14% in the experimental group versus 26% in the control group. Symptomatic intracerebral hemorrhage and adverse effects were similar between the groups. Last, patients who suffer from middle cerebral artery infarction can have a mortality rate secondary to elevated intracranial pressure. Neurosurgeons often perform decompressive craniectomies when such situations arise. Multiple studies were conducted over the years to determine the efficacy of this practice. There were 3 randomized controlled landmark studies and a meta-analysis of these studies that aimed to address the issue. The first trial was the decompressive surgery for the treatment of malignant infarction of the middle cerebral artery, DESTINY, that was published in 2007. The second trial was the sequential design, multicenter, randomized controlled trial of early decompressive craniectomy in malignant middle cerebral artery infarction, decimal trial, that again was published in 2007. The third trial was the hemicraniectomy after middle cerebral artery infarction with life-threatening edema trial, HAMLET trial, that was published in 2009. 2007, a meta-analysis of the above 3 randomized control studies were conducted while the above studies were ongoing. The aim of the study was to determine whether performing decompressive hemicraniectomy in patients who suffered malignant middle cerebral artery territory infarct had good long-term outcomes. The study showed that more patients in the hemicraniectomy group had an MRS of less than equal to 4 in comparison to the control group. The study also showed that survival rate in the hemicraniectomy group was higher than in the control group. This meta-analysis favored decompressive hemicraniectomy in patients with malignant middle cerebral artery infarction who underwent surgery within 48 hours of stroke onset in order to reduce mortality and improve MRS scores in survivors. In conclusion, our understanding of stroke over the years has evolved tremendously. This is evident in the new treatment options that we have for patients. Unfortunately, ischemic stroke still remains a major public health concern that can undoubtedly cause severe disability. Even with increased efforts for public education and primary prevention, neurosurgeons still need to be able to manage ischemic strokes efficiently. I would like to thank Dr. Rahimi, Augusta University Neurosurgery Department, and Scientex Conference. These are the references that were used, and I'd be happy to take any questions.